Thank you for joining today's webinar. Dr. Jackie Powers will now begin the program.
Hi, good afternoon or good morning for those of you joining us. Thanks for joining us today on your break or during your lunch hour. Today's program, a case conversation, is entitled Initial von Willebrand Factor Antigen Values in Adolescent Females Predict Future Values. This work was presented at the 64th annual meeting of the American Society of Hematology in December 2022, and the manuscript was published in September 2023 in the journal Hemophilia. I'm Dr. Jackie Powers. I'm an associate professor of pediatrics in the Division of Hematology Oncology at Baylor College of Medicine in Houston, Texas. I serve as the section chief of hematology within the Texas Children's Cancer and Hematology Center. I also founded the Center for Iron Disorders and Nutritional Anemias program at Texas Children's. For a few years, I served as the hematology director for the Adolescent Hematology and Gynecology Multi-D Clinic, formerly termed our Young Women's Bleeding Disorders Clinic, and I continue to staff that clinic. I am joined today by my authors, co-authors and colleagues, Dr. Clay Cohen and Dr. Mark Zobeck. Dr. Cohen is an assistant professor in our department and division of Hem-Onc at Baylor College of Medicine and Texas Children's. He also serves as the associate chief of hematology and is the medical director of our Hemophilia Treatment Center, and now serves as the hematology director of the Adolescent Hematology and Gynecology Multi-D Clinic. Dr. Zobeck is also an assistant professor in our department and division of hematology oncology with a primary focus in oncology. His research focuses on using data science to improve how we care for children with cancer and blood disorders, and his focus is on predicting clinical outcomes for patients to improve medical decision-making. So we have been invited to speak with you all today by the Foundation for Women and Girls with Blood Disorders. The FWGBD mission is to ensure that all women and girls with blood disorders are correctly diagnosed and optimally managed at every stage of life. With this, the FWGBD aims to provide education to healthcare professionals on the medical consequences and unique issues for women and girls with blood disorders. Since its inception, the foundation has focused on realizing its vision through these objectives, as you can see displayed on the screen, which we'll leave on for a few moments. And then just some general housekeeping information for the webinar. To ensure the best sound quality during the program, please remain muted. However, you will have the opportunity to participate in a Q&A session by using the question function on the chat box on your control panel on the right-hand side of your screen. And we'll address all the questions, or as many as we can get to, at the end of today's presentation, but please feel free to go ahead and enter questions into that box at any time during the presentation. The next few slides will go over the accreditation process. In support of improving patient care, this activity has been planned and implemented by Cinemed and the Foundation for Women and Girls with Blood Disorders. Continuing education credits will be provided, and a follow-up email will be sent to attendees explaining how to obtain 1 hour of CME or CE credit for the program after its conclusion. This activity is being provided independent of industry support. The learning objectives of today's case conversation. At the completion of this activity, learners should be able to discuss the development of a predictive model for diagnosis of von Willebrand disease in adolescent females, compare the differences in patient outcomes when intake is performed at outpatient clinics versus acute care settings, and interpret the findings of the predictive model of von Willebrand factor to ultimately and accurately diagnose von Willebrand disease. All provider employees in control of content have indicated that they have no relevant financial relationships to disclose, nor do any of the speakers. As far as receiving credit, all attendees will receive an email an hour after the program's conclusion with the evaluation, and this link will help you claim your 1 hour credit. The accreditation overview is also available as a handout, and the link will be shared again at the conclusion of the program. So before we begin the presentation, we have a few polling questions that we're going to ask you to complete. Sorry. So the first question is really just an attendance information for the foundation. Please let us know how many people are joining you today for this conversation, if you're watching individually or in a group setting. Okay. For the second poll question, we would like to know, do you obtain von Willebrand factor diagnostic labs for adolescent females who present for acute evaluation of heavy menstrual bleeding, or HMB? And perhaps we can share the results now. Okay, 84% do and 16% do not. So we'll see how today's presentation might impact those results. And then our final polling question before the presentation, can go back to the poll. So in adolescent females who have had von Willebrand testing, at which von Willebrand antigen threshold would you consider not needing to repeat testing? So you've checked von Willebrand factor values. If it's at 60, 80, 100, or 120, would you feel comfortable not needing to repeat the testing? Or do you repeat in everyone? So please take a moment to answer that. And if we could see the results from that poll. Okay, very good. So there's a wide variety there. So I will now turn over the slides to Dr. Clay Cohen, who will be presenting the findings from our project.
Thank you, Jackie. So to begin the talk, I'll begin with a case presentation that I'm sure is familiar to most everyone that is here today. So a 14-year-old female presents for emergency care with heavy menstrual bleeding, fatigue, and syncope. Laboratory work was done in the emergency department that showed a significant anemia with a hemoglobin of 7.2, slightly elevated platelet count of 658,000, von Willebrand factor antigen of 73%, and then a glycoprotein activity of 67% with a significant iron deficiency and a ferritin of 4. In the emergency room, she's treated with a blood transfusion and received intravenous iron. And now she presents to see you in hematology clinic 1 month later. So this, being a common presentation, was the background for why we performed this study, because we're always left wondering how exactly to interpret these normal von Willebrand factor values. As a background, heavy menstrual bleeding is often the initial bleeding symptom in adolescent girls with von Willebrand disease, but the interpretation of von Willebrand factor lab values and diagnosing accurately von Willebrand disease is challenging in the setting of acute heavy menstrual bleeding. The reason for this is that von Willebrand factor values are elevated with acute stress, physiologic stress, illness, and inflammation. Pretty much all of these are present when an adolescent female presents with acute heavy menstrual bleeding. One pediatric study suggested that patients and children with von Willebrand factor levels over 100% may not require repeat testing to rule out von Willebrand disease. However, whether that threshold is appropriate for adolescent females is unknown, as the mentioned study was done in all children ages birth to 18 years of age. So briefly touching upon heavy menstrual bleeding and von Willebrand disease, heavy menstrual bleeding is present in the vast majority of women with von Willebrand disease, estimated between 74 and 92%. And the overall presence of women presenting with heavy menstrual bleeding having von Willebrand disease is 13%. So a lot of women that are being seen for heavy menstrual bleeding do have von Willebrand disease. And it can be challenging to diagnose because of the falsely elevated laboratory values in that acute setting. But it is important to accurately diagnose and timely diagnose von Willebrand disease to prevent and manage current and future bleeding symptoms, to prevent unnecessary surgical and dental bleeding, and provide adequate family counseling to siblings and potential future pregnancies and births. So assuming that a normal value that is picked up in the acute setting and waiving off any additional workup is potentially dangerous to these patients. At Texas Children's Hospital, we are developing a management algorithm for adolescents who present to the emergency department with heavy menstrual bleeding. This was a quality improvement project for a recently graduated fellow class. And one of the questions that has come up and that was heavily debated was whether von Willebrand factor laboratory values and assays should be included and recommended in the initial workup. The aims of our study was to understand the von Willebrand disease diagnostic testing patterns in adolescent females within the Texas Children's Hospital network, and to develop a prediction model to determine whether repeat testing is indicated based on initial von Willebrand factor testing results in adolescent females with heavy menstrual bleeding. So the methods for our study: we included all female patients ages 9 to 21 years who had any von Willebrand testing at a Texas Children's facility, which is over the greater Houston Metroplex, over a 5-year time span from January 1st, 2017 to December 31st, 2021. We collected initial and subsequent laboratory evaluations, which included von Willebrand factor antigen and activity, factor VIII activity, hemoglobin, and ferritin for these adolescent females. We went back and excluded patients who had any von Willebrand testing between 2010 and 2016 to ensure that the von Willebrand tests that we were picking up were the initial tests and not actually follow-up tests from years before. To compare across the cohort, we decided to use von Willebrand factor antigen values as the comparative lab rather than von Willebrand activity. And the reason for this is because there was an inconsistency over the Texas Children's system and over the time course of the study about what assay was used, whether it was ristocetin or the glycoprotein-based assay. So to allow for comparison of all laboratory values, we decided to use the von Willebrand factor antigen value, and that's what I'll be referring to, or will be referring to, for the remainder of the talk. So as the ASH, ISTH, NBDF, and WFH guidelines on the diagnosis of von Willebrand disease state that von Willebrand disease is diagnosed if there is the presence of a low von Willebrand factor under 50% in the setting of abnormal bleeding, as in heavy menstrual bleeding. So we are presuming that the patients that are having von Willebrand testing performed in this study were doing so because of heavy menstrual bleeding. It is a presumption that we took, and because we had a large cohort of patients, which I'll show you in a minute, we weren't able to go back and verify that every female adolescent was having von Willebrand testing because of heavy menstrual bleeding. However, that was a presumption that we made, and for our cohort, abnormal von Willebrand factor antigens was defined as 50%, consistent with the guidelines on diagnosis of von Willebrand disease. So now I'll turn this over to my colleague, Mark Zobeck.
Thanks, Clay. I will present briefly about the statistical dimensions of this project, and then I will be jumping back in a little bit later to present some of the results. So for the statistical analysis, we fit a Bayesian linear regression model, and it was designed to predict follow-up von Willebrand factor antigen levels based on previous levels and other variables. So go ahead, Clay. The predictors that ultimately were included in the model include the previous von Willebrand factor level. So you had to have at least 2 levels to be included in this cohort because we needed some data to predict the future for patients. So previous von Willebrand factor level, age, location of previous lab draw, and that was divided into whether the location was acute care, which included the emergency center or inpatient settings versus outpatient settings or non-acute care. And then finally, the number of von Willebrand factor antigen levels from the first evaluation was the final variable in the model. The current and previous von Willebrand factor levels were logarithmically transformed. So, there's statisticians love logarithms. They have nice mathematical properties, and it made the model perform better. That's the I think that's sufficient to say for our purposes. So there are some log transforms. And go ahead. And then previous von Willebrand factor level and age were modeled using restricted cubic splines. This is just fancy terminology for being able to say that we could fit curves instead of just straight lines to the data, and that made our model more accurate, which is great. And we'll show you those results in just a second. And the prediction intervals were our primary way that we analyzed the data to identify these thresholds that we'll be talking about for whether or not repeat testing is indicated. And I will go into this more as we get into the results. And now I will hand it back to Clay.
Thanks, Mark. Very grateful for Mark. I would not be able to understand or present that in any informative way. So the demographic and clinical characteristics of our cohort are seen here. These are all patients that had any von Willebrand testing over this 5-year time span, which was a total of 6,125 adolescent females who had von Willebrand testing performed, at least one von Willebrand test performed. The median age of the cohort was 14 years. As we are in Houston, Texas, we have a large Hispanic population. You can see the race breakdown of the cohort here. The median body mass index was 23. And then the location of the initial von Willebrand factor testing is shown here, with the most common location being an outpatient adolescent medicine or pediatric gynecology clinic, followed by another outpatient pediatric clinic, then outpatient hematology, followed lastly at 13% by acute care, which Mark mentioned was defined as either the ER, an inpatient setting, or an ICU setting. The median initial von Willebrand factor antigen of the entire cohort was 89. The median hemoglobin was 12.4, and the median ferritin was 13, which is consistent with iron deficiency for the entire cohort. So moving on to the segment of the cohort that had repeat von Willebrand testing done. Out of the 6,100 patients, over 1,200 did have repeat testing performed. And we broke those down into 4 subgroups, including those that had normal initial being over 50% and normal repeat von Willebrand factor, low initial being below 50% and low repeat, low initial, normal repeat, and then normal initial and low repeat. So you can see the age breakdown of those 4 cohorts here, the initial von Willebrand factor antigen and activity. No surprise, there is difference, but it's no surprise based off of the subgroups of the cohort. There was no difference in the initial hemoglobin between these 4 subgroups. There was no difference in the ferritin either. Important to note that each subgroup had a median ferritin that is consistent with iron deficiency. I'll turn it back over to Mark.
All right, great. So now we will present the results of the modeling that will deliver the thresholds or the values for follow-up that we will be discussing. First, I will show you, or what you see on the screen, are some technical specifications for how well the model performed. And the big message from the slide, if you hear nothing else, is that the model performed very, very well. So it was good for making this type of prediction that we wanted to make. More specifically, I'll walk you through the slide. So if you look at panel A, the curve right in the middle of the screen, the darker blue line represents the observed values in our cohort for about 1,200 people, the observed values of von Willebrand factor antigen levels as like the baseline level. So this is a density curve. So you see most patients had values less than 100, but there's a long tail to the right where plenty of patients came in between 100 and 200, and then a few presented much higher than that. And then the light blue line are predictions for the von Willebrand factor antigen level from the model itself. So we are trying to reproduce the dark blue curve would be perfect calibration, so to speak. And that's what we were trying to capture with the model. Now, you can notice that the light blue, and the reason why there are kind of mini fuzzy looking blue lines is that these are simulations from the model. So we ran 500, 1,000, I can't remember, simulations to look at what the predictions looked like. And what would be nice is if the peaks lined up exactly, and you can see that the light blue lines, so the simulated values, the predicted values, fall a little bit shorter than the observed peak, meaning, or what that meant was that if you look at the tails of the distribution, so over on the left, more towards 50 to 0, you see the light blue line is kind of shifted to the left of the dark blue line. That meant the model was predicting a little more lower values than were observed in the cohort. And also, if you go to the right, looking between 100 and 200, the light blue lines are kind of shifted towards the right of that dark blue line, not completely, you know, there's still overlap, but the model was just tending a little bit to predict higher values than were expected in that range. But to be honest, that's okay for our prediction task because we were focused on this lower range. And so what we can say is the model was pessimistic. Like the model was saying that people were more likely to have a lower von Willebrand factor antigen on follow-up than was actually observed. So if anything, we were being very severe in our assessments of what the next value for a von Willebrand factor antigen would look like. And then if you look at the plots in the lower row in B and C, these are showing us that the model reproduced the kind of weird dimensions of our distribution that we were trying to predict. It reproduced it very well. So we're looking at what's called skewness, which is how right-tailed the distribution is. And again, if you look at the top row, you see that long right tail. That's skewness. And then kurtosis is how heavy are the tails, so how fat are they? But anyway, the big message is the dark blue line is the observed skewness and kurtosis of the distribution. The light blue lines are the simulated skewness and kurtosis from the model. And what we want is exactly what you see. The light blue lines fall around the dark blue lines, which is perfect. So that we were getting we were reproducing the shape of the distribution. So all of this, again, the big message is, if you hear nothing else, we were doing very well with predicting the distribution, predicting the values that we wanted. And then finally, I give you one more metric of how the model was performing, which is this cross-validated R-squared. So cross-validation is when you say, well, we did an analysis, but we don't want to fool ourselves by saying, because we saw some data, we predicted it well, but if we see new data, maybe we won't predict the data as well. And what this value demonstrates is that even the best way we could assess, how we do on new data out of sample, so to speak, is that we would still predict it very well. R-squared of 0.69 means we were predicting a lot of the expected variation in the distribution, and this is pretty good for these types of prediction models. So overall, big message is we were doing well with the modeling, so this is useful and this is good to reason with. That's the message. All right, go ahead, Clay. Now I'm going to show you, I demonstrated the model's working well, so now let's think about it. Here are how the expected von Willebrand factor antigen levels changed based on different settings of the variables that we used. And we'll just walk through this again, plot by plot. So looking at panel A, What you see here is on the x-axis, previous von Willebrand factor antigen level. So, you come into the emergency center somewhere and you have your level drawn, and you have, say, a value of 100. Based on that value, what does the model predict will be your next value if you have a follow-up? And what's important here is that I'm telling you we're predicting based on different variables. So in the background for this prediction, there's other variables that we needed to set. Like we assumed for this plot, your age was at the average age in the cohort, which for us, the average age was 9. So for a 9-year-old, we also had different, the number of antigen levels from the first evaluation. So was this your first follow-up, your second, your third? We were assuming this was your first follow-up. So for a 9-year-old with your first follow-up, and then where was your previous level at? Was it in an acute care location or was it outpatient? And we were assuming, I think we were assuming it was an acute care location. So for a 9-year-old who was previously evaluated in an EC, who's at their first follow-up and their previous value was 100. I know that's a lot to keep in mind, but here we go back to the plot. So our previous von Willebrand factor antigen level is 100. You go up on the y-axis and you see what is your expected, what's the next value that you expect based on this value of 100. And you can see it's slightly lower than 100. So the expectation is that if you were a little on the higher side, then it kind of came down a little bit. And if you scan across the x-axis here for this curve, you see that from 0 to 100, it's kind of, you expect to have a kind of a similar but slightly lower value in your follow-up von Willebrand factor antigen levels. And then you can see there's kind of this scoopy aspect of the curve as you go higher. And that's that non-linearity that I mentioned earlier, so that we could kind of model curves instead of just straight lines. But that is what we saw in the data. So that's how the expected level changes based on your previous von Willebrand factor antigen level. How it changes based on age. So here, again, the kind of expectation is you were previously evaluated in an acute care setting. This is your first follow-up, and we just assumed your factor level was 96. This is just all to facilitate us showing how the predictions change by age. And you can see the younger ages from 9 to 15 kind of remains somewhat stable, and then 15 and upward, the expected value actually rose some. So the expected value on follow-up for those older kids was estimated to be higher. And one thing I'll say, the blue line represents the median value, the median expected value, and then the gray shaded region represents basically the confidence intervals. We call them credible intervals when we're doing Bayesian modeling, but it's the range of values that are compatible with the changes or the predictions that we saw. So, but the trend is that the kids on the older end of the age spectrum were expected to have a slightly higher value on follow-up. And then we come to number of von Willebrand factor antigen levels from the first evaluation. So again, was this your first one after your initial lab, your second, your third, or your fourth? And I think that 4 actually represents 4 or greater, but we had very few children who had greater than 4 evaluations. And so what you see is, as you have repeated levels, the expectation is actually kind of goes up over time. So you were low, and then perhaps a doctor said, we're concerned about this low level, so we're going to repeat it. But then as you repeated it, most children normalized. And so so it rose slightly is the takeaway of that trend. And then finally, for acute care versus non-acute care, the relevant comparison is that if you were previously evaluated in an acute care location and you had a follow-up, you were expected to be slightly lower than if you were previously evaluated in a non-acute care location, so in an outpatient clinic. So the patients in acute care tended to have higher levels that it came down, so to speak. So again, just zooming out from this plot, what this shows you is just how these variables were contributing to the overall predictions. This is kind of like if you were doing odds ratios or hazard ratios, if you're interpreting one of those types of plots, these would be the same types of things. So these are just associations. And one thing I'll say is when doing prediction modeling, you want to be careful interpreting or over-interpreting the coefficients, because we weren't specifically trying to understand each coefficient. So these are just associations that we saw. And if we wanted to really dive in deep to explain these associations, we would need to do more work. So there's some caution warranted, but overall, as I walked you through the plot, this is how we can think about these variables. Okay. And then finally, so again, I showed you the model was performing well. We had these variables that were changing our expected follow-up von Willebrand factor antigen levels. And so finally, what we did is we took our cohort and we predicted the expected level based on the previous von Willebrand factor antigen level and all of their other values. And what this plot shows is it shows the for our cohort, the baseline von Willebrand factor antigen levels compared to the predicted or the follow-up level. And in the light gray points, those are the observed values. So you can see if your observed value was 50 previously, there's one that's right at 50, and then we then observed one, the next von Willebrand factor antigen level that was around 120. You can see there at the 50 on the x-axis, you go up and you see there's like a light gray dot, that's 120. So that was in our data set. So those are all the raw data that we observed. And then we overlaid on that what the model predicted would be the follow-up level. So based on different von Willebrand factor, the baseline evaluations, what would be the next level? And the light blue bars are our prediction intervals. So there's an 80%, so 80% of predictions fell within the darker area. 95% of predictions fell within that little kind of medium blue area, and then 99% of predictions fell within the light blue area. And then the central point in those colored strips is the median prediction. And what we wanted to see is, so based on everything we knew, we had a well-performing model. We knew there was all this variation based on your previous location of evaluation, how many lab draws you had, your age, your previous level. What would be the best expectation in your level that we could predict based on your initial evaluation? And so you can go ahead, Clay, and we'll march through the boxes here. So take, for example, this 50. At an initial value of 50, then the light blue line gives you your range of expected von Willebrand factor antigen levels on follow-up. And our specific question was, how many of those patients are expected to be below 50, consistent with the diagnosis of von Willebrand factor deficiency? And at a level of 50, that 47% of predictions were lower than that threshold of 50. So with Bayesian modeling, you can just say this with a straight face and it works well. There's a 47% chance of the level being below 50 at a baseline value of 50%. So this is now, you know, us trying to predict what is the probability of having von Willebrand factor less than 50 at given levels. So that's how you interpret this value. So then we'll go to the next one. At a level of 60%, the child is evaluated in the emergency center, and you see a value of 60%. That gave us a 70.8% chance. Oh, I'm sorry, this is of having a normal level, so this is being above 50. I said that wrong initially. So there's a 70% chance of being above 50. There's a 30% chance of being below 50. Okay, march up to the next one. If they initially had a value of 70%, then there's an 85% chance that you're above 50. And we can keep going. We can say 80%, there's a 92% chance, 90%, there's a 96.6% chance, and so on. You can see the trend proceeds until we got to greater than 120%. There was maybe one, maybe two patients in the cohort that had a level subsequently lower than 50, so there's a 99.4% chance of having a value above 50. So this is what we saw. So we modeled the variables well, we modeled the data well, we saw some associations with the variables, and we were able to confidently make predictions based on the data that we saw, predictions about the chance of being above or below 50 based on an initial evaluation. Okay, so that steps us through the modeling and gets us to the primary result of the paper. And with that, I will hand it back to Clay.
Thank you, Mark. So the results, one of the major results was that hemostatic evaluation that was performed by either adolescent medicine or gynecology was more likely to identify abnormal von Willebrand factor testing compared to testing in the acute care setting. And I think the way that we interpreted this is because von Willebrand disease is so strongly hereditary, that if von Willebrand disease is present and yet undiagnosed in a family, heavy menstrual bleeding is more likely to be the norm in the family and maybe less likely to be seen as an acute emergency. So maybe they're more likely to present in the outpatient setting, whereas those family members where heavy menstrual bleeding is not been seen before, not been experienced, is more likely to see that as an acute emergency and present to the emergency room. Additional patient demographic variables, including race, ethnicity, and BMI, were not associated with follow-up abnormal von Willebrand VWF testing, though. So the conclusions based on the results that Mark demonstrated, repeat testing in adolescent females with heavy menstrual bleeding whose initial von Willebrand factor antigen values over 90% is unlikely to identify an undiagnosed von Willebrand disease patient. And that iron deficiency screening should be performed in all females with heavy menstrual bleeding. Going back to the overview of our cohort, the median values of the entire cohort and the subgroups of their ferritin values were all less than 15, consistent with iron deficiency. So while we're worried about a bleeding disorder, specifically von Willebrand disease, iron deficiency must also come to mind for these patients as well and treated effectively. Additional studies are needed to determine the effect of iron deficiency and anemia on von Willebrand disease laboratory testing in adolescent females with heavy menstrual bleeding. As we're seeing their follow-up von Willebrand factor testing, presumably the iron deficiency and the anemia that was present when they likely first presented for evaluation should be resolving with time. So that's one outstanding question that we have. What is the impact of the resolved iron deficiency, the resolved anemia on repeat von Willebrand factor testing? So how do our findings compare to some prior studies that were done in pediatrics or adolescents? One study by Brown et al. Demonstrated that there was a 93.2 negative predicted value when initial von Willebrand factor antigens were over 100% in 39 adolescents with heavy menstrual bleeding. They also demonstrated that there was a 25% reduction in von Willebrand factor seen in outpatient follow-up compared to the initial acute care values. So the 100% threshold is similar. We were able to show that that can be reduced to 90% in adolescent females. Doshi et al. Demonstrated that negative predictive values for von Willebrand disease were 94.1% for von Willebrand factor antigens of 75% and increased to 96.6% when von Willebrand factor antigens were 100%. This cohort and this study that I previously mentioned at the beginning of the talk was comprised of male and female patients aged 0 to 18 years. So it was hard to use these negative predictive values and this paper to our patient cohort. Our study was able to identify 1,200 adolescent females who did have repeat testing of von Willebrand factor labs and was able to provide statistical probabilities of normal repeat testing based on initial value. So in practicality, we feel like our study is able to give us a real predictive number that you can use in clinic, that you can use when you're evaluating these patients to determine, do you need to do repeat testing? So let's return to our initial case presentation. There's a 14-year-old female who presented to emergency care with heavy menstrual bleeding, fatigue, and syncope. So her labs, if you remember, her von Willebrand factor antigen was 73% and her glycoprotein activity was 67%. You're seeing her a month later in clinic follow-up. So how are you interpreting these values? Are you going to put her through an additional von Willebrand assay test? Well, according to our statistics, we believe that you should, unless you're willing to accept a 15% chance that she may have von Willebrand disease. To us, that would be too high to accept. We chose 90%. as the cutoff that we use now in our adolescent hematology and gynecology clinic, as it provides an acceptably low false negative result at 3.4%, whereas the 15% with an initial antigen of 70% seems a little too high to accept. Okay, now we're going to move to 2 polling questions to see how you will interpret lab values going forward, knowing our results and knowing our data. So with this question, what initial von Willebrand antigen would not require to retest in the following scenarios? So I believe the first question, it took it away from me, but that's okay. So I think the first question we'll go through is a adolescent female who presents for acute care with iron deficiency and heavy menstrual bleeding, but there's no family history of heavy menstrual bleeding. There's no family history of bleeding disorder, and this is a previously healthy patient who has a low ferritin, normal hemoglobin, but presenting for heavy menstrual bleeding. So which of the von Willebrand factor antigens in this patient would you accept and not retest? Okay, you were paying attention. That's great. So 73% would not retest if it's 90%. Some willing to accept a slightly increased negative, false negative at 80%, and a similar number needing to get higher values of over 100%. Okay, great, thank you. So that we have one more polling question and a similar scenario. However, in this case, this is an adolescent female with multiple family members with heavy menstrual bleeding. She has, and family members who have had chronic iron deficiency. And this patient presents with severe iron deficiency anemia, requiring a blood transfusion, kind of like the initial patient that we discussed. So similar question, what initial von Willebrand factor antigen would you accept and not require repeat testing for this this patient who is more impacted with more of a family history? Okay, thank you. So now it seems that people are, or you are requiring a higher threshold to be convinced that this patient does not have von Willebrand disease, with about 70% requiring that the initial value is over 100% to accept that she does not have it, whereas the 90% threshold was reduced to 25%. And we agree. So we think that we can use the results and the statistics and the predictive table based off of your index of suspicion for your patient having von Willebrand disease. So that's great. So in the first patient that we went through, it may be more acceptable to use a lower von Willebrand antigen threshold, as they may seem less likely to have a bleeding disorder. Whereas the second patient, it seems likely that there is a bleeding disorder present, whether von Willebrand disease or another one. So requiring a higher initial von Willebrand factor antigen does seem to make sense.
Okay, thank you so much, Clay and Mark, for that presentation and review of the study. If you both can turn on your webcams now, we're going to move on to the Q&A portion of the talk. So for anyone in the audience, would love to hear any of your questions. And although you cannot unmute and speak, if you do have any institutional practice around von Willebrand testing that you do at your own center, if you have a combined clinic, or if you just work independently as a hematologist, it would be interesting to see in the chat what your own practice is about when to repeat or what thresholds you use there, and whether the study impacts that decision making. One question I had for you, Clay, that I know we've kind of talked about, but I want to hear in this setting is, what would you recommend now for whether a girl presenting to the ER with heavy menstrual bleeding should have von Willebrand testing or not? Is it worthwhile to get it in that setting, or would you recommend holding and simply doing it as a outpatient?
Yeah, I think before this study, I would have said to not do it because it would be hard to interpret. If it's normal, I'll probably need to repeat it unless it's severely low. I think outside of a very strong family history and you have a high index of suspicion of a severe von Willebrand disease, like a type 3 or something that might not be falsely elevated, I think it's fine. Well, that's how I felt before. Now I think it is fine, because if you have someone that comes in with von Willebrand factor antigen values of over 100, over 150, then I don't repeat the testing. If it is below that 90 threshold, then I do repeat the testing. So from that sense, I think it is fine, and it has changed my practice and opinion on initial testing.
Great, I agree. I think it is worthwhile now for the same reason, which I didn't before. We do have a question from Dr. Hope Wilson from Birmingham. Did you account for estrogen use and its impact on levels between initial and repeat testing?
Great question. Thank you. And hey to everyone in Birmingham, my former home for 4 years. We did not account for estrogen. That's a great question, as we know that higher doses of estrogen will elevate your von Willebrand factor values. I think that is one of the variables, along with anemia, along with iron deficiency, that can be further explored and seeing as to how those affected probably the follow-up values. I would presume that most patients who came in with heavy menstrual bleeding were not yet on estrogen, but maybe. So we do not know. It was difficult with such a large cohort to go out and tease through the medications, but that's something that should be looked at going forward.
And then kind of a related question from Dr. Simino, not directly related to the study. However, how do you take OCPs into account? And this is more about just general practice. I've heard various opinions, mostly that the dose of estrogen in current OCPs is not high enough to increase von Willebrand assays. However, historical practice in my institution has been to discount normal values and consider repeat testing no matter what level of estrogen is in the OCP.
I think our practice, speaking for my colleagues, is that if they are on some of the more standard low dose estrogens, if it's under 35 micrograms, then we take those values as they are and not worry about the lower or normal dose estrogen. If they're on a high dose taper, we often will wait until that taper has transitioned to their normal hormone supplementation. So I guess for standard hormone, low dose hormones, not that we ignore that they're on it, but we accept their values as they are. But if they're on a higher dose taper, then we'll often wait until that is done to retest.
Yeah, and I think for the most part, our gynecology and adolescent colleagues always use the low dose. Sometimes we'll get the referrals for girls from outside practitioners that use kind of older OCP, but as far as our own center, most practitioners use low dose, I think. This is a comment from Dr. Menon down the street. Oh, sorry.
Sorry, yeah, can I chime in real quick, Jackie, about
Yeah,
that?
please.
Just going back to the modeling and the interpretation of the variables, this is those types of questions are very good questions that our study was just not designed to answer well. And so that's why we encourage caution if you're trying to look at, the comparison between outpatient versus acute care evaluation. We couldn't tease out those types of differences. So this was all of our predictions have all of those types of practices baked into the cake, because many girls were started on OCPs after their initial evaluation. And so our predictions were, under normal practice at Texas Children's Hospital, what do we expect to see? So it was in some ways accounted for, but at the same time, we really can't tease those things out.
Thank you, Mark. Appreciate that. A comment from Dr. Menon, who's at UT Houston down the street. She has had a patient who came in quite anemic, whose levels were above 100, were around 100, 120, but later was found to have a low level in the 30 to 50, the low von Willebrand range. It was an N of 1, but because of it, she always worries she's missing, so repeat at least once, particularly if their values were obtained when they were anemic. So I think just kind of goes back to what you were mentioning, Clay, about we can't really assess the level of anemia and its impact.
Yeah, and I think if someone presents with severe iron deficiency anemia, is in the ER, their hemoglobin's 5 or something like that, then probably you need to raise your threshold for the likelihood of them having a bleeding disorder like von Willebrand disease, and you might need to you might accept only a very small false negative. So I agree. That patient is much different than someone that comes in with a hemoglobin of 12 in terms of their likelihood of having a bleeding disorder.
Okay, so we have a question from Dr. Nicole Kendall at Akron Children's in Ohio. Is your prediction model able to make any predictions regarding those without bleeding symptoms, such as those patients referred just for a family history who would technically require levels less than 30 for a diagnosis? So
I'm not going to try to be Mark and sound smart statistically, because that will fail. But what I'll say is, we presumed that all of the patients in the cohort had heavy menstrual bleeding, but in reality, probably the 6,100 patients that had initial testing and the 1,200 patients that had follow-up testing, there were probably a number of those that were not having testing for heavy menstrual bleeding. So we're applying this to be used for heavy menstrual bleeding. But I think, so the question was, could the initial testing in someone with like a family history?
Yeah, so it's how would the model work for someone who's referred in whom you need like no personal bleeding, so the diagnostic level would be less than 30. Does the model still hold for that?
I would think it should. It's within the age range. We didn't specify who was having testing, just as long as they're a female aged 9 to 18 and had initial testing. So I don't know what you have to say about that, Mark.
Yeah, so again, the model was designed to just under normal circumstances, just vanilla operation of our evaluation process for von Willebrand factor deficiency. How many would we expect to be deficient on follow-up testing? But again, we used 4 variables that were informative for making this prediction. But as we showed in one of our questions, if your index of suspicion is higher, that kind of segments out a patient from this general vanilla population that we were modeling, and that's perfectly reasonable to use other information that as a clinician, as an expert. The model is not designed to tyrannize the decision making. It's designed to give some information which is based on the normal operation, what can we expect? But as you know more or less about the patient, it's perfectly reasonable to adjust your expectations and adjust your practice. And we're just trying to give some information around which you can adjust your practice, which is those tables of predictions that you saw. So I hope that answers the question some or speaks to it. I'm happy to continue the dialogue if we need to.
Great. I think that makes sense to me. I don't see any other questions in the chat. I think we've had a nice Q&A and we have just a couple minutes left. So I think I want to go ahead and thank Drs. Cohen and Zobeck very much for your presentation and your answers in the Q&A. I'll have a few things to wrap up for everyone else online. I just want to mention, if you enjoy this case conversation, there is another one already scheduled for the end of July, July 31st, featuring Dr. Jim Bucell and Dr. Doug Cenas, who'll be presenting on immune thrombocytopenic disorders in women. So there's should be a link in the chat and then also available on the case conversation webpage. I also want to mention on behalf of the Women and Girls with Blood Disorders that the biennial conference will take place September 13th to 15th in Long Beach, California. And actually, both Dr. Cohen and myself will be participating on one of the plenary sessions on an iron debate focused on screening and treatment practices. So we would love to see all of you there. It should be a great meeting and a really beautiful location. And then finally, I just want to mention that the foundation is pleased to provide this program at no cost to attendees, and participants again will receive the evaluation following this program in your registration email in about an hour. So please go ahead and complete that evaluation, and then you can get your claim for continuing education certificate. Thank you all for attending. It was great to see some familiar names and colleagues on there. And we hope you enjoyed everything, and please join us for any future programs. And if you need any additional information, you can always go to fwgbd.org. Thank you very much. Have a great day.